This is the bipolar presentation that begins on page 865 of your text, so please make sure you're on that. This is a psych condition, so we're using DSM-5 for the criteria for a diagnosis, and then the documents, the guidelines that are used for treatment decisions are listed for you in the guideline box. The one that's important to know here is the DSM-5 for criteria. Okie doke. Let's look at why we have this picture here. And so somebody's looking a kind of little devilishly happy, and then we've got somebody looking very depressed, and that is because this is bipolar. There are two disease states going on concurrently, and patients flip from one to another. So we have major depressive disorder, and it's really bad depression. And then we've got mania, and the mania is often very poor judgment, decision-making skills, but the mania can be different types. And this determines whether you've got the primary types of bipolar, which is bipolar 1 and bipolar 2. Most patients are down here, bipolar 2. So let's start with that first. They have the depressive disorder, and then they have what's called hypomania. So they get a little wired. They're feeling much better. They might do stupid things like gamble in Las Vegas, go to the mall and buy a lot of stuff and charge up bills, sexual indiscretions, gambling. In other words, their thinking isn't clear. But other people, their thinking's pretty clear. In fact, I strongly suspect that Newt Gingrich, who was running for president, actually is bipolar 2 because he keeps screwing around with people in the back seat of cars. That's not very good for a politician. He's extremely ego-driven and thinks he's the hottest thing in the world. And this type of ego that is often present in bipolar, where people think they're great, but everybody else is a screw-up. So they're often very difficult to deal with. Some people say, oh, and he rambles and you can't get him to shut up, right? Anyway, that's Newt, and he was almost president, so what does that say for the rest of us? Now, some people think that some Wall Street people who are very driven, these CEO exec types are bipolar 2. But we also have a lot of bipolar patients that aren't that driven, but they have all these symptoms. Now, your bipolar 1, this is the serious, what we used to call classic manic depressive period. So they have the depression again, but their mania is full blown. They can stay awake for days, going at 1,000,000 miles an hour. Like some people think, for an example, Vincent van Gogh may have been bipolar 1 because at the end of his life, he painted 40 paintings in 40 days. And then he killed himself at the end of the 40th day when he sunk into the depression. However, I just finished a biography of him, and that guy says it could be he was poisoned from the chemicals that were in the paint because he kept sticking his paintbrush to moisten it in his mouth. Anyway, I don't know, but that staying awake for long periods of time, full-blown mania, is the type 1 patient. So we've got different types. Look on page 865, and in the second paragraph, I want to look about halfway through the second paragraph where it begins with the symptoms. The symptoms of mania in bipolar 1 can be so severe that they can require psychiatric hospitalization, impair social or occupational functioning, or have features of psychosis, such as hearing voices or delusions, whereas bipolar 2 people don't get that. They're not psychotic. In fact, Michael Douglas's very beautiful wife, Catherine Zeta-Jones, she has bipolar 2, and she doesn't get psychotic. She just gets manic and then falls into depression. Okay. So the criteria here is for mania. If you want the criteria for the depression, then go look in the depression chapter. That's where it is in the book. Let's look at the mania. So inflated self-esteem or grandiosity. People often think they're much more They're very important. Decreased need for sleep, very talkative, flight of ideas. So sometimes people jump from one subject to another and you're like having trouble even listening that fast. Sometimes, not always, easily distractible, but other patients are very goal driven. So that depends. So you've got this easy distractible or increase in goal-directed activity, which could be like that driven CEO type of personality. And this is the dangerous thing, excessive involvement in pleasurable activities that have a high risk of pretty crappy consequences, not being able to make the good judgments there. Another issue that often goes with this inflated self-esteem or grandiosity is that these bipolar patients often have a very bad victim mentality. You know, I could have been very famous opera star, but you didn't let me sing, and I could have succeeded in work, but she was against me, you know, blaming other people. Not everyone has that, but it's often present. It can be very grating. Okay. Now, bipolar is one of the things that is really being diagnosed a lot these days. We've got kids on bipolar medications that maybe they're just going through a hard time, right? Maybe they're just, going through a stage and you put them on an antipsychotic. We're going to look at that because that can lead to behavior that maybe they don't need to be on an antipsychotic. Maybe they need parenting. So we'll look at that a little bit because it can lead people to make bad decisions. Now, for the pharmacotherapy, I want to say something on the background here, which is that we have lithium, which is really an oldie but a goodie drug. Many people are on it. It helps them very much, and they're fine on that. This is a mood stabilizer. That's what we want. Why are we using a stabilizer? To keep the mood from bouncing back and forth to different states. In fact, that's critical here because what happens is that if you just give like an antidepressant because you catch the patient in the depressive part of bipolar, then what you can cause is you can cause the mood to go from depression to mania, depression to mania, depression to mania, which is cycling back and forth. And what we really want is a mood stabilizer. So lithium works, it's used, it's got safety risks we're going to look at. And then the other ones that are most commonly used now are the second generation antipsychotics. Valproate is used, it's a little bit hard to take, so we're going to look at that too. Carbamazepine has been used for many years. It's not currently recommended. It's not a very good mood stabilizer. It's a much better anticonvulsant, and we should leave it there. But you do see some patients on that as well. Okay, turn the page, please, to 867. And we need to talk about a couple of things here, which is if you look at the second paragraph, it says second generation agents can be added to mood stabilizers or vice versa. So you can start on this, and then if you need something else, it's not working right, you can add on a mood stabilizer afterwards. Lamotrigine is used for both the depressive stage and to stabilize the mania. But remember that with lamotrigine, which is an anticonvulsant, you've got this risk of very severe rash. So whether you're using it for seizures or you're using it for bipolar, you better be very careful that you're using the very slow titration. That's why this comes in the dosing titration pack, like in a blister card, because we're always concerned about severe rash with this drug. Okay. Now, let's look at the paragraph under that where it says antidepressants are not recommended unless the patient is on a mood stabilizer and then they have residual depression so that we can avoid the cycling issue. Now, many people with bipolar 2 are female. It's more common in females than males. And that means we're going to have pregnancies with people on these drugs. So let's think about the risks that are involved. Lithium is a bad drug for the baby. if the mother has it in her system when she's pregnant. It causes increase in congenital cardiac malformations, serious heart problems, and actually that's the primary risk, but some of these babies have mental retardation as well. Valproate is the absolute worst. I would put this as a big bad news in pregnancy drug because you get neural tube defects, fetal valproate syndrome, which includes permanent cognitive impairment. It really needs to be avoided during the first trimester, but both of these are pregnancy category D. Why is that? Because the FDA is saying if the benefit outweighs the risk, then maybe you should use it. For example, if you have a woman who's trying to have sex with anybody that goes down the street when she's pregnant because she's manic, she doesn't have good judgment, she could expose that baby to HIV disease. That would be pretty bad. Maybe you could decide to use these. However, you don't need to because we have some second generation agents now you could use that would be much safer. It's really, these are really bad drugs. Okay, carbamazepine causes problems as well, but I'm going to skip that and focus on lithium and valproate. If I had to guess, I would say this is very important because this one actually in the last couple of years was, I forget when, but it was changed to a D/X. It's a D if you're using it for seizures. It's an X if you're using it for migraine prophylaxis because there's other agents and you really don't need to use it. But you see, the FDA is saying seizures, maybe that's the only thing that controlled your seizures, where migraines you can deal with other ways. Because each time a person has seizures, they permanently lose neurons in their brain. A seizure is a very serious thing. And so that's why this is rated D, but you don't need to use it for migraines. There are other things, for goodness sakes. Maybe it's the only thing that controlled your seizures. Some people have very difficult to control seizures. And then lithium, best wishes for the baby whose mom was on lithium. Okay, now, on page 869 is valproate. I'm not going to review that drug here because it's a very important drug, and Sherry reviews it during the seizure lecture. It's the same information I would be giving, so if you don't know that, please go back and look at the seizure lecture for a very complete discussion of this drug. Now, the same thing I'm going to say for lamotrigine on 8671. Besides mentioning the rash, this is primarily a seizure drug. It just happens to be used for this. So please go back to the seizure lecture for a full review of lamotrigine as well. I want to spend my time here talking about the one that you don't see anywhere else, and that is lithium. Okay, so we did bipolar medication in pregnancy. Oh, I forgot something that's really important. When you have a patient who's acting psychotic, now for our purposes, if they're acting psychotic, they could have schizophrenia or they could have bipolar 1, right? These are the two primary things. I mean, there's other things, like, for example, if you don't let hospitalized patients sleep, they get psychotic, right? In fact, there's a term called ICU psychosis that can happen in your critical care patients because they check them so often. That's why those pulse ox machines that go on automatically are so terrific, because the nurse doesn't have to wake up the patient. But do you know that that's what's causing the psychosis? Maybe they're taking illegal drugs. And so this is a picture of a tox screen, and the result from this patient was there was a trace of hydroxyzine visceral in the blood, but this would check all these things. Now, this is either blood or urine, because some things show up on blood, other things show up on urine. So generally, you need to get both a blood and urine. But I'm just trying to point out to you that a tox screen is going to absolutely be done if you suspect that it could be illicit drugs as well. And so we're looking for, was a tox screen done in our schizophrenia section and in our bipolar section. Okay, now I want to spend my time with lithium. So let's skip to that. It comes as a solution, and the solution, the large container, has been in shortage. This has gotten more expensive because they're using lithium batteries in all kinds of things now. And a lot of the lithium comes from countries in South America that the United States is perpetually angry at. So we've had issues with getting enough lithium. And so that's created problems for our patients. But anyway, that's what it is. And so I'm showing you the solution, the capsule. It comes as a tablet. And the litho-bid, when you see a BID, like macro-bid, litho-bid, I hope you can realize that's a BID medication as it is. I have a slide here to show you that lithium is an element in the periodic table. And the reason I put this slide in here is because so you can keep in your mind that there is nothing to metabolize. What would you metabolize? It's just lithium. It's just an element. And so that means that when you swallow it, the body's got to excrete it renally. We're going to look at lithium in detail, but let's talk about one thing first, which is the renal clearance issue. So here's the kidneys, and they are very smart organs, but they have a little bit of a problem, which is the kidneys cannot tell if something is lithium or sodium. They go out the same transporter mechanism. And so what happens is the kidneys can think that lithium is sodium, and that can cause problems with lithium being subtherapeutic or toxic. So what does this mean? This means that you have to maintain the salt concentration steady in your diet if you're on lithium, because if you decrease the salt concentration, the kidneys are going to say, hey, salt is dropping, I'm going to retain more sodium, therefore they're going to retain more lithium. It's the same thing to them after all, and that means that the lithium level can become toxic. This is just a picture of the kidney showing you that lithium and sodium are going in, they compete out of the, for reabsorption and excretion. Okay, now, if you were to take too much sodium, and this I think about because when I travel, I go through the Philly airport sometimes, and they sell these pretzels that I look at those pretzels and I think, wow, if someone was on lithium and they got that much salt, the body would attempt to excrete that extra salt because it has to maintain the salt at isotonic levels. And so what it would do is it would decrease the sodium, and then it would want to decrease the sodium, but it would decrease the lithium. And so what happens is you would become subtherapeutic. So here's how it works out. If you increase your sodium intake, your lithium level goes down. If you decrease your sodium intake, your lithium level goes up because the kidneys are trying to retain sodium, they retain lithium. So we need to be careful about that, and that's an important part of counseling. The other thing about lithium is it makes people thirsty, and consequently they pee a lot. And so when you dispense lithium, you want to tell patients, look, you've got to keep water with you. You have to drink 2 of these a day, more if you feel hot. And you have to make sure that you don't get dehydrated. What happens if you get dehydrated? Your kidneys can go into acute renal failure. And that would be a really bad problem here because that would make the lithium toxic. Let's look now, please, at the lithium table on page 872. And the only brand that's available right now is this litho-bid. Otherwise, we're using just the generics, like this is obviously generic lithium solution. So the dosing is divided anywhere from 150 to 900 milligrams a day, and you're looking for this therapeutic level. So the level is measured in milliequivalents. See, most drugs are in milligrams or micrograms, but lithium, like sodium, is in milliequivalents per liter, and that's a trough level. When you're measuring a trough level, you're measuring right before the next dose. That's the lowest point. When the patient is acutely manic, you can go up a little higher to 1.5, but if you do that, you might have to, but you're gonna have to drop it back down to below 1.2, because at 1.5, you've already got symptoms of toxicity. Look at my hands here. Lithium causes a mild tremor, like I'm doing right now. But when you see this, which is a coarse tremor, that means the patient is lithium toxic, and they will also be slurring their words. They will be, ataxic, like walking, like they look like they're gonna fall down at any moment. And the problem with lithium toxicity is it could end up as lithium-induced fatality. Look at the toxicity here. So at 1.5 and higher, you've got that coarse hand tremor, vomiting and diarrhea. I'm going to write that down here, vomiting and diarrhea, because a big problem for patients with lithium is stomach upset and loose stools. Stomach upset and loose stools, which you could call diarrhea, but I don't like to call it that because it's really loose stools, not diarrhea. Whereas when you get this, much worse, you've got likely lithium toxicity. Lithium causes a lot of stomach upset, and so it's always taken with food, and that's a big issue for us. Many patients need to take it right after the meal rather than before. We want to use long-acting forms of lithium, but often it needs to be split up so the patient doesn't get as nauseous with it. All right, go back to the therapeutic range in the beginning, in the second column, and it says titrate slowly to help the patient tolerate that primary side effect. And if they have tremor during the day, thirst, confusion, or nocturia, then for any one of those reasons, you could try dosing it at night. Then they would just be peeing out more the following day. If you do that, of course, it needs to be a long-acting formulation. So side effects: GI upset, take with food. Cognitive effects: lithium makes you slow mentally. It does. Cogwheel rigidity. So I have a picture here of someone being tested for cogwheel rigidity. Let me show you what you do. If somebody's been on lithium chronically, this isn't toxicity, it just happens, and you tell them to loosen their hand, when you try to move it up, it moves up in increments that they call a cogwheel, because it's similar to like the wheels on one of those Amish buggies, where it has these cogs, and so it moves up in increments like that. And then fine hand tremor and weight gain. Lithium is a weight gain drug, and patients do not like to gain weight, so we need to be careful about counseling them about how they're eating and physical activity. Okay, I mentioned the polyuria and polydipsia. Let's talk about hypothyroidism, because it's not uncommon, and this will always be hypothyroidism. If you've listened to the arrhythmia lecture, Sherry probably mentioned amiodarone can cause hypo or hyper, mostly hypo. This one's always hypo if it causes it. And so when you're looking to check for thyroid, you're always checking the same thing: the thyroid stimulating hormone and the T4 hormone, free T4. And so if the free T4, the thyroid hormone, is low, as it would be in hypothyroidism, the body secretes more stimulating hormone to try to get more production of thyroid hormone. So they're always opposite to each other, and this is what you would see in hypothyroidism, but the patient, of course, would also have symptoms of feeling more fatigued, putting on more weight. They won't really get constipated. That's a sign of hypothyroidism, but the reason they won't is because they're on lithium, and lithium causes loose stools. Okay, lithium is serotonergic. How it is, I have no idea, but it is. And so if you put it with too many serotonergic drugs, you could end up with serotonergic toxicity. Lithium is cardiotoxic, especially if it gets into the toxic range, which is why if you look under the level of greater than 3 milliequivalents per liter, that's a big bells should go off, because this patient could die from that. Arrhythmia is one of the things you'll see with a toxic lithium level. Okay, now the other thing here, if you're looking under the monitoring, please highlight renal function, because lithium, not in everyone, but in some patients, can actually damage the kidneys. And please appreciate, you should write that down, lithium can be renal toxic, because see, it's very important, because I'll just use this for some writing space. Lithium is 100% cleared renally. So you can't give lithium unless the kidneys are good. Otherwise, you would get toxicity. But see, rarely, but it can happen, lithium itself can damage the kidneys, and that would make the lithium level toxic. So for both reasons, we have to monitor the kidneys anyway. But keep in mind, that doesn't happen commonly, but just because I've seen it happen, I want to point it out. You're more likely to get tested on, I would think, on the things that we're underlining here. Look at the level of greater than 3, and notice that you've got CNS depression. These patients are getting you can't even talk to them at this point. Arrhythmias, seizures, irreversible brain damage, coma, and this can cause death. Okie doke. And because of the cardiac problems, if you look under the monitoring, if the patient's over 40, we want a baseline EKG, or I guess it should be technically called an ECG, to make sure that they're doing okay. And let's look at the lithium drug interactions. So decrease salt, increase lithium. NSAIDs we just do not use with lithium, because they can make the patient toxic, and because patients use ibuprofen or naproxen, aspirin over the counter, we just tell them not to use those. Use Tylenol, and if you need something stronger, you have to ask the doctor. ACEs and ARBs can affect the level, because they initially, when you start them, the patient is the creatinine goes up a little bit. Okay, and that's the most important thing. Caffeine and theophylline, just keep it constant, and make sure you know about serotonergic toxicity. Please read through the counseling. The second generation antipsychotics are being used quite a bit. These are discussed in the schizophrenia lecture in quite detail, so you should review it there. I'm not going to review it here, but I did try, when I put this chart here, to put the main issues with all of these drugs in a kind of abbreviated form. So I hope that's reasonable for you to study from, and then go back to schizophrenia for more detail on these very important agents. So these are schizophrenia drugs being used for bipolar disorder. Okay. So the point of this talk was primarily to review the criteria, be able to recognize a bipolar case, to review lithium, which is only used here, except that lithium is sometimes used as adjunctive therapy now for depression. But if you get tested on lithium, I would think it's for a bipolar patient. And then we're throwing in some seizure drugs and some psychosis drugs, which are sometimes used here as well. Okay, thanks for listening. That's the end of the bipolar section.